Good afternoon and welcome to our congressional briefing and national webinar on the report Pain in the Nation, the Epidemics of Alcohol, Drug, and Suicide Deaths, hosted by Trust for America's Health, or TFAH for short. My name is Tim Hughes, the External Relations and Outreach Manager at TFAH. We would like to thank our speakers and audience for being with us today. Real-time captioning is provided today by Nancy Grinley. Next slide. For captions, click on More at the bottom right of your screen with the 3 dots. Next, click on Closed Captions. Next slide. We encourage you all to share your thoughts and questions about today's presentation by typing them into the Q&A box. We'll try to answer as many as we can as time permits. To open the Q&A box, click the Q&A icon at the bottom of your screen. From there, select Enter when you are ready to submit your question. Next slide, please. And now it is my pleasure to introduce the moderator of this event, Dr. J. Nadine Gracia. Dr. Gracia is the President and CEO of Trust for America's Health. She is a national health equity leader with extensive leadership and management experience in federal government, the nonprofit sector, academia, and professional associations. As President and CEO, she leads TFAH's work to advance sound public health policy, address the social determinants of health, advance health equity, and make health promotion and disease prevention a national priority. Welcome, Dr. Gracia.
Thank you, Tim, and thank you to all of you for joining us today for this briefing and this important discussion. As Tim stated, my name is Nadine Gracia, and I'm President and CEO of Trust for America's Health. First, I'd like to welcome you all and also thank our esteemed panelists for participating in today's briefing. We are so honored to have you join us. Next slide. Our agenda for today is on this slide. After the presentations from our panelists, we'll have time for discussion and questions from the audience. Now, our briefing today focuses on the rising deaths across the nation from drug overdoses, suicide, and alcohol-related causes. We're going to highlight policies and programs to address the mental health and addiction crises and policy recommendations and approaches that advance strategies to promote mental health, well-being, and resilience. Before we introduce our panel, I'd like to start with a brief overview of Trust for America's Health's 2023 Pain in the Nation report, which was released earlier this year. A copy of the full report, including state-specific information, is available on our website at tfah.org, that's TFAH.org, and we'll include a link in the chat. Next slide, please. The TFAH Pain in the Nation report series has tracked the nation's epidemics of alcohol, drug, and suicide deaths since 2017. Now, as I begin to share these data, let me first say how important it is to not lose sight that these data represent people. Lives lost of a family member, friend, neighbor, colleague, or other loved one. And we truly bear that in mind as we engage in this work. Our latest report includes newly released data showing that 209,225 Americans died due to alcohol, drugs, or suicide in 2021. And that's a record number of such deaths in a single year. Specifically, drug-induced deaths were up by 14%. Alcohol-related deaths, which were up for all age groups except for youth ages 10 to 17, increased by 10%, and the suicide rate increased by 4%. Now, although all these deaths from these causes were up across the US population in 2021, the largest increases occurred among certain populations of color, as well as people living in the South, the West, and rural regions of the country. Next slide, please. So what are the trends and key takeaways that we're seeing? Well, first, the combined rate of US deaths due to alcohol, drugs, and suicide rose 11% in 2021. And if we look at this over a longer term, these deaths have been on the rise for over 2 decades, doubling over the decade of 2011 to 2021 from over 104,000 deaths to over 209,000 deaths. And between 2016 and 2021, a span of 5 years, the escalation in the rate of drug overdose deaths was more than 60%. When we look more closely into the data for 2021, increases were largely driven by deaths from synthetic opioids like fentanyl, cocaine, and psychostimulants, including methamphetamine. Our report also makes clear that populations of color suffer disproportionate rates of substance misuse, often due to longstanding social and economic inequities, including structural racism and community disinvestment that can lead to lack of opportunities and feelings of hopelessness. In 2021, for example, drug overdose death rates were highest for Black people, and Native Hawaiian and Pacific Islander people experienced the largest increase in overdose deaths during the year. We also see disparities in alcohol-induced deaths, with American Indian and Alaska Native people having the highest rates of alcohol-induced deaths when compared to other population groups. American Indian and Alaska Native people, along with Black people, also had the highest rate in suicide deaths between 2020 and 2021. Now, in presenting this data, it's important to put this into context, that these disparities are rooted in underlying and longstanding structural and systemic inequities, some of which were exacerbated, for example, during the COVID-19 pandemic. For example, Black households were more likely to experience job loss and food insecurity, and American Indian and Alaska Native children were more than 4 times more likely to lose a caregiver compared to white children during the pandemic. Historically, structural racism, intergenerational trauma, inequity and inequality of opportunity that endures across generations, a lack of access to healthcare, and other social and economic factors have resulted in higher rates of health disparities for many populations of color. Next slide, please. In this year's report, the special feature focuses on youth mental health and well-being, given the concerning mental health crisis among our nation's youth. And as you'll see on this slide, the data show that suicide among youth has increased in tragic proportions over the past decade. We're seeing that suicide is really driving this crisis. Specifically, over the last decade, deaths from alcohol, drugs, and suicide rose 65% among youth ages 10 to 17. And the suicide rate among this age group increased over 70% over roughly the same period. Unlike most age groups, increases in suicide have driven the increases in death rates among youth. We're also seeing worse mental health outcomes for certain populations. Our report notes that the American Indian, Alaska Native, and LGBTQ youth face a higher risk of poor mental health, suicidal behaviors, and suicide. And we're seeing contributors to these through social media and other issues, where although youth suicide rates have been increasing for decades and peaked in 2018, the impact of social media and disruptions from the COVID-19 pandemic have clearly contributed to the youth mental health crisis. In 2019, for example, 37% of high school students reported persistent feelings of sadness, and in 2021, that percentage increased to 42%. There are also some new impacts that we're observing. Concerningly, the biggest recent increases in suicide rates have occurred among populations with historically lower suicide mortality, with notably high increases among girls, among Asian American, Black, and Latino youth, and among youth living in the South. Next slide, please. It is clear that our nation has been suffering from a mental health and addiction crisis for many years, even predating the pandemic. And it is a crisis that certainly needs urgent attention. We know what policies and programs work to prevent deaths of despair. And we know what we need to do now is invest in those programs and policies. Our report includes recommendations that really fall under 3 specific priority areas. First, that we should invest in prevention by promoting policies and programs to address the social and economic conditions that influence health outcomes and reduce adverse childhood experiences and the impact of trauma. That Congress should also increase support for substance use prevention, for mental health and resiliency programs in schools, and bolster the continuum of crisis intervention services. And you're going to hear more about these types of services from our panelists today. Second, we should address the worsening drug use and overdose crisis by directing resources and efforts toward youth substance misuse, implementing policies to address the risks of psychostimulant use in addition to opioids, and promoting harm reduction policies to reduce overdoses and infections. States and local governments can also address rising rates of alcohol-related deaths by increasing pricing, limiting the density of alcohol outlets, among other evidence-based measures. And finally, we should transform the mental health and substance use prevention and treatment systems by promoting equity in mental health through increasing the diversity of the workforce and enhancing access to culturally and linguistically appropriate services, increasing community capacity to provide services, integrating mental health and substance use services with other forms of care such as primary care, and increasing equitable access. Federal agencies should also work to improve data accuracy and timeliness and completeness and deliver positive messaging on mental health screening and treatment to underserved populations to reduce stigma. So with this overview of the Pain in the Nation report and really the stark trends and timely recommendations in mind, we're going to now transition to our panelists and their presentations. We will hold questions until after the presentations, but just a reminder to please submit your questions in the Q&A box, not the chat, and we'll move to those questions after we complete the presentations. I'm now pleased to welcome our panel. Next slide, please. Our first panelist is Dr. Deborah Howey, who is the Chief Medical Officer and Deputy Director for Program and Science at the Centers for Disease Control and Prevention. In this role, Dr. Howey is responsible for establishing, strengthening, and maintaining collaboration and coordination across CDC's national centers, including infectious diseases, chronic disease, environmental health, injury prevention, and public health infrastructure. She also provides overall direction to and coordination of the scientific and medical programs. Dr. Howey also serves as the designated federal officer for the advisory committee to the CDC director, working directly with private and public sector constituents to prioritize CDC's activities and address key areas, including data modernization and health disparities. Our second panelist is Dr. Shairi R. Turner, who is an internist and pediatrician with expertise in trauma-informed practices. Dr. Turner currently serves as the Chief Health Officer at Crisis Text Line, leading the organization's external policy, advocacy, and partnership initiatives related to mental health. Crisis Text Line is a national not-for-profit organization that provides free 24/7 text-based mental health support and crisis intervention in English and Spanish. In this role, she is fervently committed to addressing the youth mental health epidemic. Prior to joining the Crisis Text Line, Dr. Turner served as the first Chief Medical Director for the Florida Department of Juvenile Justice and served as Deputy Secretary for Health and the Interim State Surgeon General for the Florida Department of Health. And our third panelist is Shelby Rowe, who is the Executive Director of the Suicide Prevention Resource Center at the University of Oklahoma Health Sciences Center, the only federally supported resource center devoted to advancing the implementation of the National Strategy for Suicide Prevention. Ms. Rowe is a leader in the suicide prevention field with over 15 years of experience and collaborates extensively with other leaders across the US and internationally to advance suicide prevention efforts. She is a member of the Suicide in Women and Girls Task Force for the International Association for Suicide Prevention, the National Action Alliance for Suicide Prevention Executive Committee, and the RI International Board of Directors. She is an award-winning artist, a mother of 3, and a suicide attempt survivor. She received the 2021 American Association of Suicidology Transforming Lived Experience Award and was recognized as the 2016 Chickasaw Nation Dynamic Woman of the Year. So as you can see, we have an incredible panel of speakers, of experts, and of colleagues and partners with whom our organization works. It is now my honor to welcome Dr. Howey as our first panelist from the Centers for Disease Control and Prevention. Dr. Howey, I'll turn it over to you.
Well, thank you so much for the opportunity to join you today. And I'm really honored to be here with such esteemed colleagues and look forward to the discussion. Overdose, suicide, adverse childhood experiences, and excessive alcohol use are urgent issues in every community. And as an ER doc, I saw this on the front lines. We also know that these are interrelatable, preventable, and really closely tied to CDC efforts to address the mental health crisis that our nation is facing. And it's also one of our director's priorities. So today I'll provide an overview of each of these issues and end with really the importance of having a coordinated approach to these challenges. Next slide, please. And next slide. So CDC recently launched the newest iteration of our Overdose Data to Action Cooperative Agreement to help state and local health departments stop overdoses in their communities. We now have 2 funding opportunities, one for states and one for local jurisdictions. This allows us to directly support 40 city, county, and territorial health departments and is responsive to congressional language to reach communities directly. And together, these cooperative agreements are awarding $280 million a year for 5 years to address evolving overdose crisis in our nation. In addition, we are currently funding 26 tribes and tribal entities for overdose prevention activities. Next slide. So across the agency, we have 5 public health strategies noted here on the slide. Our mission is to end this crisis by using data to drive innovation, tailoring prevention in local communities, partnering broadly and addressing underlying factors, including a central focus on health inequities, and preventing or reducing adverse childhood experiences, which are key risk factors for substance use and overdose. Next slide. So when we talk about excessive alcohol use, including binge drinking, this increases the chance of other substances use. And one CDC study found that about 1 in 4 people who binge drink also report other substance use in the past month. This can increase the risk of overdose if alcohol and certain other substances, including opioids or benzos, are used on the same occasion. So to prevent alcohol-related harms, CDC is funding 12 states to increase their capacity in alcohol epidemiology and prevention. And we are also funding a training and technical assistance center to support states and communities in the prevention of alcohol-related harms. Next slide. We very much appreciate the FY23 appropriations increase for suicide prevention. This funding supported an increase in the number of awardees for comprehensive suicide prevention, adding 7 new awardees who are shaded here in pink for a total of 24 recipients. To support this program, we are dedicating approximately $21 million per year. Next slide. So recipients are implementing a comprehensive public health approach and selecting evidence-based prevention strategies from our Suicide Prevention Resource for Action, with a special focus on populations that are disproportionately affected by suicide, such as veterans, tribal populations, rural populations, LGBTQ youth, and other young adults. For example, Massachusetts is educating students about the relationship between suicide and depression, aiming to really prevent suicide by increasing help-seeking behaviors and promoting connections between peers and caring adults. And 20 of these recipients use funds to support emergency departments to collect near real-time non-fatal suicide-related outcomes, such as attempts and ideation, so states can quickly respond to changing patterns. And in New York, they use this data to mobilize their surveillance team to collaborate with prevention programs to increase access to integrated care systems for people who use drugs and are at risk for suicide. Next slide. So adverse childhood experiences, or ACEs, are potentially traumatic events that occur in childhood that can undermine a child's sense of safety and stability. This can include, but is not limited to, growing up in a household with mental health or substance use problems, or experiencing or witnessing violence. The toxic stress can derail healthy brain development and affect how the body responds to stress. ACEs are associated with at least 5 of the top 10 leading causes of death and have a cyclical effect that perpetuates risk across generations. Next slide. Unfortunately, we know that ACEs are far too common, and a recent CDC study involving US adults found that nearly 2/3 have experienced at least 1 ACE, and 1 in 6 people experience 4 or more ACEs. And certain groups reported higher rates, such as women, American Indian and Alaska Native adults, non-Hispanic multiracial adults, adults with less than a high school education, and adults who were unemployed or unable to work. Next slide. So CDC is funding 12 recipients through the Essentials for Children program, Preventing Adverse Childhood Experiences through Data to Action program, which launched this week or this month. We thank Congress for the increased appropriations in 23, which allowed us to support additional recipients. And we know that by creating safe, stable, and nurturing relationships and environments for children and family, we can prevent ACEs. Next slide. So awardees are funded to enhance state-level surveillance and implement data-driven prevention strategies from our resource for action pictured on the screen to prevent adverse childhood experiences and promote these positive childhood experiences. In Georgia, they use this funding to increase access to early childhood home visitation programs to ensure a strong start for children and promote social norms that protect against violence and other adversities, and encouraging parents to recognize and seek help when needed. Next slide. So we know that there is a strong link between substance misuse, suicide, and ACEs. And people who experience ACEs are more likely to have a physical, mental, or behavioral health challenge, including future experiences with substance use and suicidal behavior. Without successful primary prevention of ACEs and mitigation of their consequences, this has that cyclical effect that can really perpetuate risk across generations, increasing the risk for overdose, suicide, mental health challenges, and other negative health and well-being outcomes. So in all of our efforts, whether it be focused on suicide, overdose, ACEs, or excessive alcohol use, we must recognize how these public health threats interrelate, and we must pursue coordinated, comprehensive strategies that address these shared underlying drivers. Next slide. So we recently launched the Behavioral Health Coordinating Unit at CDC to align and amplify the agency's mental health, well-being, substance use, and overdose activities across the agency. We know that mental health challenges are complex and that there is no single solution that will solve the problems we are facing today. But I am confident that this new unit will foster innovation, collaboration, and professional passion that will improve mental health across the United States, especially for our nation's young people. Both Dr. Cohen and I are very committed to the prevention of mental health and substance use issues. And this is one of our 3 focus areas at the CDC. Addressing getting upstream of this crisis alongside our other 2 focus areas of fall-winter respiratory season preparedness and supporting young families. We really want to approach this as a team sport. We know that by working as a team with shared priorities and shared accountabilities, we'll be able to accelerate the impact of our efforts for America's health. So we are prioritizing and being tactical, having a collaborative team-based approach at CDC, where we'll prioritize where we can make progress in the next 9 to 12 months, laying the groundwork and infrastructure for longer-term approaches. An example is, how can we bring public health data and best practices on overdose alongside treatment services and healthcare in the community? And what can we accomplish in the near term using this approach? And how does this set us up for even more success in the future? Next slide. So I just want to stress that these challenges are preventable and what we do today matters. So thank you again for the opportunity to join you, and I look forward to answering your questions. Thank you.
Thank you very much, Dr. Howery, for such an informative presentation. It is exciting to hear about the development and launch of the Behavioral Health Coordinating Unit and certainly CDC's commitment truly in addressing mental health and addiction. We're now going to turn to Dr. Turner from the Crisis Text Line. Dr. Turner, I'll turn it over to you.
Yes, thank you so much for inviting me here for this opportunity. I think this is just such an important discussion for us to continue to have with all audiences. So I'm Dr. Shayari Turner, Chief Health Officer, Crisis Text Line. Next slide, please. And here we are, Pain in the Nation. Next slide. Okay, so just a little bit about Crisis Text Line, because we really view ourselves as part of the crisis continuum, and that's what I want to discuss today. So Crisis Text Line is a nonprofit organization. We provide free, confidential, 24/7, high-quality text-based mental health support, crisis intervention in both English and Spanish. We are powered by very dedicated volunteers. Over the past 10 years, we've trained over 65,000 people and engaged in more than 8 million conversations. Last year, we engaged in more than 1.3 million conversations and exchanged nearly 40 million messages. Anyone can reach us when they need support by texting 741-741 or texting hello to 741-741 or hola to 741-741. They can reach us on WhatsApp and web chat. And we're always accessible to our volunteers as well, if anyone is interested in volunteering. Next slide, please. Okay, so crisis intervention services, thank you. When we think of crisis intervention services, we have to think of the continuum from prevention to intervention, to late stage intervention. So prevention or early intervention can help us avoid crises from escalating into more significant problems. Crisis intervention services provide immediate help and support. So ultimately, we're looking at saving lives, protecting vulnerable populations, and contributing to the overall well-being and resilience of communities. And crisis intervention specialists are really professionals who are trained to provide this emotional support, non-judgmental listening, and availability during times of crisis. And ideally, what we're focused on is this decreased reliance on law enforcement and recognizing that anyone who is in crisis intervention space has to be culturally responsive and culturally relevant. Next slide. So looking here visually, so we can see the crisis intervention continuum. Ideally, this is what many communities are moving towards. And we're finding, everyone is in a different place on this continuum, but it would start with the person in crisis, and they're calling hotlines, or they're texting 741-741, or call, text, chat to 988. And most of those conversations are de-escalated. So 80% or more are resolved through the phone, text, or chat. But for those who need more assistance, emergency services are then enabled. And ideally, we will see that as a mobile crisis team, but depending on the community resources, that can be ambulances, it can be law enforcement. But as we build out the continuum, we're focusing across the country on enabling the mobile crisis units, the mobile crisis teams to be available with professionals who are trained to help those in crisis. Now, most of those situations can be resolved then in the field. But those who need crisis facilities then are not taken to emergency departments or jails, but instead are taken to facilities short-term to help them deal with their acute crisis. Ideally, then 68% are discharged to the community, and ultimately with the goal of remaining stable within the community, but that always requires this post-crisis wraparound. So services that are available at all times for those who we know are in need. And in a continuum like this, we know that we're going to see and anticipate decreased use of jails, emergency departments, and inpatient settings for those who are in crisis. And ultimately, that is the less costly avenue. Next slide, please. So Dr. Horry did a wonderful job in talking about the ACEs, and we can't really speak about them enough, but it's really, next slide, childhood trauma, right? So the adverse childhood experiences speak to the abuse, neglect, and family dysfunction that exists for children from the age of 0 to our early 20s. And the impact of that, again, mood disorders, suicidal ideations, chronic physical health conditions, teen pregnancy, the behaviors that we see that impact children in the school setting wind up leading to children who are incarcerated in juvenile justice settings. And it just impairs every aspect of a child's development, cognitively, behaviorally, interpersonally. So as we look at the ACEs and we look at childhood trauma, we have to understand that addressing it early, preventatively, really will impact these outcomes of concern. Next slide. So again, alcohol, drug use, suicide, they're all connected. The report was just phenomenal in the way that it allowed us to see that state by state, by demographics, but again, highlighting that really the adverse childhood experiences increase the risk of opioid misuse, overdose, and suicide later in life. Our ACEs are associated with younger ages of opioid initiation, with injectable drugs. And I think we have to, again, cannot underestimate the impact of fentanyl that has now entered the substance abuse realm and is really contributing to overdose deaths at rates that we have not seen before. And lastly, we know that ACEs and substance use disorders, so childhood trauma and substance use disorders, have an intergenerational effect. So exposure to parental substance abuse is an ACE that is associated with increased risk of the development of a substance use disorder. And lastly, the odds of ever attempting suicide are 30 times higher for adults with 4 or more ACEs than those with no ACEs. Next slide. So trauma-informed policies for our youth. These are the systems that our youth at some point may be involved in. So you see the education system, foster care, mental health care, media is actually now a system, law enforcement, and juvenile justice. So all of these existing systems have the ability to impact our children and impact the way that our children are treated. So when we talk about trauma-informed policies and practices, each and every one of these systems has to be trauma-informed. And that means that the system recognizes and responds to the impact of traumatic stress on those who have contact with that system. Next slide. So SAMHSA really does a nice job in the 4 R's of a trauma-informed approach. So it's the realization about trauma and how it affects people in groups. It's recognizing the signs of trauma, and it's having systems that can respond to trauma and then resisting re-traumatization. So when we know someone has been impacted by trauma, it becomes almost universal precautions, as we did back in the 70s and 80s around AIDS. You approach everyone as if they've had a traumatic experience and create policies that support them within these institutions. And the policies prioritize understanding trauma and understanding the response of someone who's been traumatized. So whether it's a medical system, a mental health care system, or juvenile justice settings, these should be places that a developing child, a growing child, is supported and not re-traumatized. Next slide. Some of the prevention strategies that Dr. Ori elevated, I want to just reinforce. Every system really strengthening the supports to families. We know that the family systems are being stressed. We know that family systems are being taxed in our current national environment. So protecting our children against violence and adversity, ensuring those early starts, supporting families around daycare and childcare, teaching, skills to teachers so they understand how to approach a child who has been traumatized or demonstrates behaviors that are indicative of trauma in the home or trauma in the community. Connecting youth to caring adults and activities, and really intervening to lessen immediate and long-term harms. Next slide. So other ways to get involved with Crisis Text Line as a resource, 988 as a resource, sharing 741, volunteering, becoming a partner. So again, this is the most valuable conversation that we can have to start to support our children who we know, given the prevalence of trauma, have been affected, and who then will have mental health and physical health outcomes if we don't get ahead and support these preventative measures. Thank you.
Great. Thank you so much, Dr. Turner, for these resources, for sharing the work that that Crisis Text Line is doing. It's generated certainly a great deal of interest from our audience. We're looking forward to addressing some of the audience questions and learning more about the Crisis Text Line and important work that you're doing. We're going to now turn to our third panelist, who is Shelby Rowe from the Suicide Prevention Resource Center. To our audience, as a reminder, please continue to put your questions in the Q&A panel, and we will have a question and answer period after our third presentation. So Shelby, let me turn it over to you.
Thank you. I want to go over some basics, which is kind of a refresher. I think when we look at suicide prevention, we want to know, well, what works? In my career, I've been asked so many times, what is that one thing? If we did one thing, and I wish there was that one thing, but there's not. So we're going to, unpack. I think you're going to see that of looking at the slides of Dr. Howery and Dr. Turner. I think that's kind of an overarching theme. So let's get started with mine. Next slide. Start with the Suicide Prevention Resource Center. We are funded by SAMHSA, the sibling federal agency to CDC. We are charged with increasing the capacity to implement effective suicide prevention in the nation. And my views here reflect me, not necessarily SAMHSA or the federal government as a whole. Next slide. So I joke that we are the Library of Congress for suicide prevention. If you visit our website, we have resources and tools of so many kinds, to help for healthcare systems, schools, community organizations, state suicide prevention programs, tribal suicide prevention programs. We have online trainings. We have a multitude of resources. So I encourage you to visit our website, follow us online. We are here to help you be more effective in your suicide prevention. Next slide. So when we look at effective suicide prevention, our SPRC model, we kind of break it up into 3 chunks. It always involves a good plan. If we're not measuring it, we can't improve it. So having a good strategic plan, following the keys to success, which we're going to break down in just a minute, and using a comprehensive approach. All right, next slide. When we're looking at the comprehensive approach, this is a little different, but really, very similar to what you just saw on the screen for the CDC model. We think a comprehensive approach involves programs that cover each of these puzzle pieces, and they all work together complementary to effectively reduce suicide. So having a program to be able to identify and assist people at work, to increase help-seeking behavior for those who are in crisis, who are having thoughts of suicide, that they feel it's safe enough to ask for help. Then when they do ask for help, making sure that there's effective treatment, And that there's good care transition so that no one is falling through the gaps of asking for help at school, receiving help maybe in an emergency room, and then having that follow-up in outpatient. Responding to crisis that Dr. Turner, crisis text line and 988 are so crucial in our nation. And then having that postvention that either after there has been a death to suicide or after there's been a serious attempt, that family and that community needs help to heal, because being impacted by suicide, that is a traumatic life event. And so having that good postvention to promote healthy healing is suicide prevention. Part of that is having reduced access to lethal means, building up those life skills and resilience, the ability to have good social skills, the ability to ask for help, and then connectedness. If you remember nothing else, connectedness is such a powerful protective factor, that having where you belong, if that's your family, your created family, your tribe, like myself, your community, but having, where do you belong is a powerful protective factor that helps keep all of us safe. All right, next slide. So when we're looking at programs specifically for tribal communities, and for all communities, I have the ability with my job. I'm really fortunate. I have the privilege. I work in all types of communities and give advice. And so I always start at the same place. And then we can add extra specification, cultural adaptations, depending on the population. The identify and assist, and having people trained in your community to recognize someone's at risk and knowing what help looks like. Think of this as your people in your community that do CPR. We want to make sure that there are people throughout communities, and there's a plethora of programs to help with that. And many tribal communities have been trained in these, what is often called a gatekeeper training. Those increased help seeking. Once you know that a place is safe, that someone is safe to talk to, more likely to ask for help. And many tribes have been successful at setting up programs, either having billboards, literature. One program that I think does a great job working with young people is the We Are Native program, which is based out of the North Portland Area Indian Health Board, up in Seattle. Take a look at what they do. They've got a great program and create that safety where young people can ask questions, ask for help on all kinds of things. Having those care transitions and linkages. Some tribes, I know the Chickasaw Nation, my tribe, works closely with one of the local crisis centers in Oklahoma to provide follow-up calls so that anyone who's tribal who has received care in that emergency department or in a clinic, they're going to get a follow-up call within 24 hours from a crisis counselor to help connect them to make sure they don't fall through the gaps. Reducing access to lethal means looks the same in all of our American communities, and that connectedness in tribal communities, this can mean many different things. There are different cultural groups. It may be dancing, it may be learning beadwork. I know that there are some tribal therapists that will teach their clients, how to do traditional beadwork, or send them to a drumming circle, maybe a dance group, learning how to make regalia, or doing community improvement projects. Really being grounded in your community is that is a core value for tribal communities. You often hear talk about 7 generations, but it's very important to us to be a good relative and to be a good ancestor. And so staying connected to your community and having that role of taking care of those older and younger and those yet to come is a powerful protective factor. Okay, next slide. Next is the keys to success. If you're going on a journey, or even if you're going to the grocery store, you always have to take your keys with you. And so these are things that if you don't have these 5 things, it's hard to get your suicide prevention programs off the ground. One is centering lived experience. If you're going to go on a journey, ask the people who have been there. Ask them what they need, ask them what helped. We see that as a vital key to success. We cannot do this work alone. I'm so grateful for all of our partners and so happy to be here with two of our partners with CDC and Crisis Text Line today, and happy to be partnering with TFAH for today's webinar and many conversations to come. Having those safe and effective messaging and reporting, how we talk about suicide matters. There are things that are contagious. Hope is contagious, but so is pain and trauma. And so when we're talking about suicide, we want to make sure we're sharing those action steps. Because if we want to make sure we're sharing pain, we want to spread that. We want to spread hope everywhere, and that there is that we can survive through suicide. Culturally competent, culturally resonant approaches. You're going to use a different approach if you're in an urban community in the Bronx than if you're in a very rural community in Montana. That's going to take a different culture. Even if you're within tribal or Black communities, it looks very different in Detroit than in Atlanta or in DC. And taking that into account when we're looking at culturally competent, think C as encompassing all cultures, because there is no one size fits all, but we can usually find ways. How do we make everyone participating in our program feel like they belong? And then using good evidence-based prevention. Next. And then this just kind of review of making sure that we're using good planning. When we want something to go well, it's just as if we were starting a business, we're going to have a business plan. When we're wanting to save lives in our community, we want to have a good plan. We want to follow our plan and constantly implement, evaluate, and improve. Everyone that's on this call, the SPRC, CDC, I know the community outreach folks at Crisis Text Line and TFAH, we're all here to help. If any of you have questions of how can you prevent suicide, prevent overdose deaths in your community, we're all here ready, willing, and able to help. Next slide. That should conclude my portion. And I'm going to turn it over to Dr. Gracia.
Thank you very much, Shelby, really for those kind of tangible ways in which we can engage and really address suicide prevention, and to all of our panelists, really for your informative presentations. We have audience questions that have been lining up throughout your presentation, so we're looking forward to moving to those audience questions. The first I'll ask, and then I'm going to introduce as well as we're pulling up some of these questions. I'm pleased to be joined now by my colleague, Brandon Revis, who is our Senior Government Relations Manager at Trust for America's Health. He's going to help moderate our Q&A. I'll start with a first question to Shelby. And Shelby, you moved into speaking about this. You're a member of the Chickasaw Nation. You're a co-founder of the Indigenous Peoples Committee for the American Association of Suicidology. And we've been speaking to these broader, social and economic conditions that really undergird a lot of what we are seeing now. Can you speak more to those types of community conditions and how that's having an impact? What has the greatest impact, for example, around youth mental health and youth mental health outcomes, and how we work to address those with regards to suicide prevention?
So I do wish that there was one talking point, but I'll try to quickly summarize a cluster of things that contribute. One, there is oftentimes overlooked, over 70% of our tribal citizens in this country live in urban areas. And so some of the things that impact are the same that affect other minority groups in urban areas. Higher unemployment, lower access to care, and kind of an overall cultural erasure of tribal population. So if you are a young person coming up, if you are in New York City and you're a young person and you need mental health care, your closest IHS clinic to provide that behavioral health care is in North Carolina. So access to care can be limited for tribal populations. As we are just coming out of COVID is one big example of this was a generational trauma and it impacted grief practices. Many tribal youth, it's a strength that we have extended families, but it is a risk factor when there are deaths, and that grief practice is different. So there were a lot of families grieving multiple relatives for being in rural places where there wasn't ready access to vaccines and all of those other social determinants of health. Some of our tribal populations are very remote. And so accessing any form of healthcare, including mental health care, and then we add a layer of intergenerational trauma. Volume 1 came out, and I'm assuming at least one more volume on the impacts of the residential boarding schools on tribal citizens in this nation. And we're still seeing the legacy of that play out in our tribal families. So increased addiction, increased abuse, and just overall trauma. Our communities and families are still healing from the assault of the boarding schools.
Thank you very much, Shelby. I'm going to turn it over to Brandon to open us up for some audience Q&A.
Thank you, Dr. Gracia. Our first audience question is for Dr. Turner, and it asks how the crisis text line overlaps with or supplements the 988 suicide and crisis lifeline.
Great question. Thank you for that. So since its inception in with the start of 988, Crisis Text Line has been one of the national backup centers. So we provide text and chat backup for 988 nationally. So whenever there are conversations that cannot, when the volume is greater than what's available for local centers, Crisis Text Line is there, and we also are contracted to do the same in Spanish. So since the beginning, we've been a close partner with Vibrant and for the purpose of 988.
Thank you, Dr. Turner. Dr. Howery, a member of our audience, notes that they work in overdose prevention and much of their work feels quite siloed. Given that so many of the prevention strategies on these issues are the same, especially dealing with ACEs, do you have any suggestions or recommendations for how projects can work together across funding sources to address these interrelated issues?
Absolutely. And I see there's a similar question 2 down from that too, that talks about how funding from SAMHSA CDC can also support creative approaches for suicide, SUD, and ACEs within one initiative. Within both our suicide and our overdose funding, we do talk about primary prevention, which is ACEs. And so that is certainly something that can be done as part of that work. And we're trying to look at it from a holistic standpoint, like how do you prevent early trauma? How do you mitigate early trauma? And how do you provide recovery supports? If you've got questions, if you're looking at the funding announcements, feel free to reach out to our injury center. At cdc.gov/injury, our contact info is up there. But we agree, we can't have this all siloed. And we know that even when you look at unintentional overdoses, sometimes intentional overdoses, there's that, not that clear distinction there for suicide and drug overdose. So where we can, we try to be very supportive of that.
Thank you, Dr. Howery. An audience member also asks, from your perspective at CDC, can you talk about the trauma resulting from the pandemic that we've all experienced and how this may have impacted the concerning trends that we've discussed today?
Very much so. And I think what I would say is all these issues were here pre-pandemic. When we looked at drug overdoses, suicides, these were going up pre-pandemic. And certainly during the pandemic, became much more complex because you had things like physical isolation, job insecurity, food insecurity, issues with school. Some people lost loved ones, due to illnesses. Certainly that added stress, the uncertainty, fueled the fire, if you'll say that. But on the flip side, though, we did see things like connectedness, and after some immediate traumas, we've seen that actually suicide can decrease because people come together. And in 2022, some of our provisional data shows that actually suicide rates have gone down among youth. So I don't think there's one thing we can point to other than the pandemic certainly impacted everybody. And in some ways it was protective with some of the close connections that were formed. Other ways it was very disruptive for life. And certainly we have seen these trends continue to increase in drug overdose and suicide. And it's something that we've got to address. And I think, as my panelists have said, really focusing on some of the primary prevention is so important in addition to services so that we can really reverse this tide. And I love what Shelby said about hope being contagious. And I think that's going to be my takeaway today, is that hopefully we will all work well together to really combat this.
Thank you, Dr. Howery. Ms. Rowe, an audience member, asks, given the prevalence of sexual abuse in this nation and the surrounding secrecy and shame, what is being done to address this root cause within a comprehensive approach to suicide prevention?
That is a great question. So thank you, whoever asked that. I honestly think that sexual abuse doesn't get addressed enough in suicide prevention. I think it's a strong risk factor for both male and female. Years ago, I ran a crisis center, and I can't tell you the number of our callers that their crisis stemmed from sexual abuse. I know that we are working more at SVRC and others and working with states, and I look forward to more behind the scenes. We work closely with CDC. We try to collaborate or at least listen so that we can maximize those federal dollars and not duplicate what each other are working on, but bringing ACEs more to the foreground, because so much in suicide prevention is what happened to you, not so much what's wrong with you. And so getting in a preventing ACEs, preventing those childhood traumatic events, and then lifelong. A sexual assault is traumatic no matter what age you are. So looking forward, we don't have all the answers yet. I think still working with states, to get in and train those crisis response nurses, doctors, law enforcement who do the exams, to really work hard to try not to re-traumatize. But it is an issue that I do think we need to pay more attention to, because it dramatically increases risk for suicide for those who've been sexually assaulted.
Thank you, Ms. Rowe. Dr. Turner, can you speak to the possibility or the importance of crisis text line and other crisis services in addressing individuals who might be prior to the point of contemplating suicide, and also their role in potentially connecting individuals to broader social resources to help them with social determinants of health?
Yeah, so that's a wonderful question, because that speaks to the continuum. And on the prevention side, ideally, we're getting services and resources to individuals early. So where it might be a relationship issue, it might be something as simple as stress over homework, because at crisis text line, we see many children text in under the age of 13. So to be able to identify and provide coping strategies, problem solve, and really de-escalate a situation so that it does not become compounded, right? So one small thing that doesn't go addressed can then, the layering effect can lead to someone feeling hopeless or helpless. And we know that suicide can be such an impulsive gesture. It can be such an impulsive event. So if we're able to help individuals at the preventative side, if they're able to text crisis text line, if they're able to text or call 988, if that resource is always available and accessible, stored in people's phones, then they don't feel like they have to handle it on their own until a situation just explodes.
Thank you, Dr. Turner, and to all our panelists. I'll turn the floor back to Dr. Gracia.
Thank you, Brandon, and thank you to our audience for really such Terrific questions. And we've also seen from our audience, some of you have shared the work that you're doing in your communities, and we thank you for what you are doing to support communities everywhere. We could certainly be speaking about these issues because they're so important. We could speak about them for a long period of time. And I just want to say thank you. Our hour has already come to a close, and want to thank you all for tuning in. Many thanks to our panelists, to AI Media Captioning Service for providing those services during the webinar, to our staff and team at Trust for America's Health, and to all of you for your commitment. I think I agree with Dr. Howery. Shelby's statement around hope is contagious. Ending there is appropriate because with all of you and what each of you is doing, there is hope for what we are doing to be able to support everyone in all communities, and really to be able to reverse and end these crises. A recording of this webinar, along with the slides and additional resources, is going to be made available on our website in the coming days at TFAH.org. So we encourage you to tune in and look to our website to be able to access the recording and these resources. Thank you again for joining us. Be well, everyone. Take care.